is defined as inadequate tissue perfusion due to circulatory collapse. It is acute, life-threatening, could be treated initially, but can cause death if not treated.
The problem might be in the pump, in cardiogenic shock, the supply itself, in hypovolemic shock, the vascular system, in distributive shock, or the pathway to the pump, in obstructive shock.
Cardiogenic shock could be from acute myocardial infarction, heart failure, valvular dysfunction, or arrhythmia. Hypovolemic shock could be from hemorrhage, dehydration, or burn. Obstructive shock could be from cardiac tamponade, pulmonary embolism, or tension pneumothorax. And distributive shock results from sepsis, anaphylaxis, or CNS injury.
Skin is cold in all kinds of shock, except in distributive shock, where it is warm. If skin is dry in distributive shock, it should highlight the cause towards CNS injury, neurological shock.
Cardiac output is decreased in cardiogenic, obstructive, and hypovolemic shock. In distributive shock from sepsis or anaphylaxis it is increased. In CNS shock, cardiac output is decreased because there is loss of nervous supply to heart.
Systemic vascular resistance, which reflects afterload, is increased in hypovolemic shock due to systemic vasoconstriction. The same thing happens in cardiogenic and obstructive shock, resulting from sympathetic effect. However, in distributive shock, there is vasodilation and that decreases the systemic vascular resistance and afterload.
Treatment of hypovolemic shock is IV fluid. Cardiogenic shock is treated with vasopressor agents such as dopamine, epinephrine, and norepinephrine. Obstructive shock is treated by resolving the underlying cause. And distributive shock is treated with IV fluid, vasopressors, especially epinephrine for anaphylactic shock, and antibiotics for septic shock.